Hi everybody, I'm Giulio Bonaldo and today I have the great pleasure to be here with Professor Lorusso. Welcome back to our project and thank you for accepting our invitation, Prof.
And thank you for inviting me.
Of course, it's a pleasure. So we are going to talk about endometrial cancer, and my first question is a general question, and a big change came last year with the new FIGO classification of endometrial cancer, and for the first time the molecular profile is considered in the classification of endometrial cancer. So my question is how molecular profiling guides medical treatment now?
You are right. It's a very unprecedented moment for endometrial cancer treatment. After several years, we finally recognize that endometrial cancer is not a single tumor, but at least 4 different diseases with 4 molecular profiling and 4 different treatment approach. In this moment, we use the molecular profile as a prognostic factor to help in stratify patients according to risk group. But it's evident that the molecular profile is also predictive factor. And we know that, for instance, 7% of endometrial cancer tumor present polymutation. That's a very good prognostic tumor, and our guidelines report that stage 1, 2 endometrial cancer with polymutation should be considered low risk and should not receive any kind of adjuvant treatment. On the opposite, P53 mute patients that represent between 15 and 25% of endometrial cancer patients account for more than 75% of death from endometrial cancer. These are the most aggressive tumor, and if you have a P53 mutation, even if you are a stage 1 but with minimal myometrial invasion, you should be treated as high risk, with chemo plus radiotherapy and potentially in the future also with PARP inhibitor. 30% of endometrial cancer patients present microsatellite instability. These patients should be treated in advanced stage with immunotherapy single agent or immunotherapy in combination with TKI inhibitor if they do not present microsatellite instability. But very recently we saw at least 4 new trials evaluating immunotherapy plus chemo in the first-line advanced setting. So really an unprecedented moment for endometrial cancer treatment with a lot of new information.
Thank you very much, Prof. Yes, my second question is about, in particular, a specific treatment that is antibody drug conjugates, at a new treatment that maybe in our community right now we don't know a lot about that. So about the future, knowing the ongoing trials, what can we expect from the development of these ADCs?
We are in the era of ADC, antibody drug conjugate, represent, in my opinion, a very intelligent way to move chemotherapy to the tumor. The payload, the chemotherapy, is linked to an antibody that recognizes a target dominantly expressed on tumor cell. After the link, the drug is internalized and released inside the cell. So the side effects are less than with chemotherapy provided by IV. And this is the new era of antibody drug conjugate. Already 2 drugs have been approved in gynecological malignancies, one in ovarian cancer and the other in cervical cancer. Mirvetuximab has been approved in ovarian cancer, platinum-resistant patient with folate receptor alpha high expression. For the first time, this drug, in comparison to chemotherapy, provided a significant increase in overall response rate, duration of response, progression-free survival, but more important, overall survival. 5 months increase in overall survival is something that we never saw in platinum-resistant ovarian cancer. The other drug is tisotumab vedotin, has been approved for cervical cancer patients 2nd and 3rd line. This drug targets tissue factor, but the benefit was behind the target, so it will not be approved only for tissue factor positive cervical cancer, but for all cervical cancer patients failing platinum-based treatment. The drug has been already approved in US based on a single phase 2 trial reporting 24% response rate, but very recently we saw the results of the randomized trial comparing tisotumab vedotin versus non-platinum chemotherapy in second and third line, and for the first time also in this setting we saw a significant increase in overall response rate, PFS, but most important of all, overall survival. So the two drugs will be in few months approved also in Europe for the treatment of our patients. But beyond these two drugs already approved, we have plenty of antibody drug conjugate in clinical development in ovarian, cervical, and also at least 11 new drugs in clinical development also in endometrial cancer. So really an unprecedented moment of treatment of gynecological malignancies.
So very good news. And I would like to remember that there is an article specifically dedicated to this argument of the special issue of the International Journal of Gynecological Cancer of the last year that it's very interesting, and I suggest to read it. So thank you very much, Prof. Lorusso. I hope that you enjoy as I did during this interview, and see you soon.
Thank you so much. It's always a pleasure to be with you.
Thank you. Bye.